Your voice is not coming.
Yes, sir. So now it's 3, 2, 1. So we are live to the attendees platform. Over to you, Shekhar, sir.
Hi, good afternoon, team. Myself Shekhar Chaudhary. I'm Senior Brand Manager from Lupin. Today we have gathered over here for a webinar, which is a part of our World Allergy Week. World Allergy Week. We all know currently World Allergy Week is going on, which is from 18 to 24 June. As a part of our World Allergy Week, we have scheduled a webinar with Dr. Vijay Warad. Let me introduce you to Dr. Vijay Warad. He is from Sai Allergy Asthma Eye Children Hospital. He is allergist immunologist at another multi-specialty hospital, senior investigator for clinical trials in allergy clinical immunology at Sahyadri Hospital. He is an expert of Advisory Environment Committee on American Academy of Allergy, Asthma and Immunology, Allergy Prevention Committee of World Allergy Organization. He has 73 national and international paper publications. Moreover, he has 46 trials completed. He's a speaker for pediatricians, ENT, chest physician, dermatology, gastroenterology, IMA, Family Physicians, Physicians Association. He's an author for several journals and he has a book on allergy also. So team, the list is very lengthy. So rather than I am reading the list, I would like to call Dr. Vijay. Please come on board and take us through today's webinar. Dr. Vijay Varat, over to you.
Thank you, Shekhar, for a very good introduction. Thank you, Lipin, for always being here for the people to have awareness about what is happening latest. When I remember, just 15 days back only, I had been to the oscillometry workshop organized by you. And it was very interactive and it is always learning. 2019, when I had been to the Münster University Hospital, Germany, I found these all advanced management are done so routinely. And it is a requirement for the community, basically. It is a requirement for the community. And definitely it helps a lot for management of this patient. And considering since 1990, I'm observing this field and how the disease pattern had changed, like heart diseases, diabetes and all. The same way allergy has come up to such stage that now children's, it's a #1 chronic disease. Every third person in India is suffering with some or the other allergy. In Pune like city though, it is like every second person is suffering with some or the other allergies. And even recently I was talking to one of the marketing team and it was said like more than 70% of the population in India is consuming some or the other anti-allergics. So it's a very common problem. It is underestimated, overlooked, and time has come now to proper manage these patients. How we manage a diabetes. The same way, I always say, once allergy is always allergy, so we don't manage it properly. Only thing is that in between, there can be a window period. For example, like most of the children, they present with the eczema or infantile colics or gastroesophageal reflux. We call it like ultiyan hoti rehti hai bachon ko. So such type of patients, they may overcome that after a few months or few years. But out of that, many go into rhinitis, asthma. Again, in childhood asthma, like Pune, like city, 40% of the children are having asthma. Each and every house, there is a nebulizer. Out of that, 80 to 85% of the patients, they overcome the asthma. But their newer sensitization formation, in spite of not significant symptoms from above, the sensitization continues. The minimal persistent inflammation continues. And later on, many patients may land up into the deviated nasal septum or sinusitis or rhinoconjunctivitis or obstructive sleep apnea like snoring. Even many of them have adenoids, tonsils, throat infections, may go into adult asthma, chronic respiratory diseases. Now it has been documented now. Allergy asthma, COPD overlap syndrome. So it's not only smoker's disease, but even the pollutants, indoor, outdoor, the underlying inflammation, which continues in these patients leading to the chronic respiratory disease. Again, difficult asthmas, they are causing a cardiac problems. 30% of the cardiac arrest can be because of these complications. Obstructive sleep apnea, snoring, which is a very common problem nowadays. And because of these indoor allergens and pollens, potency has increased. That is leading to the strokes, blood pressure problems. Then again, overeating, obesity, This all connected actually. So this Th2 inflammation, that is very important. And what is happening in India is that most of the patients are treated symptomatically. When the patient in an early phase, you can see, when there is a mild to moderate sensitization, then histamine is secreted. And that's why what happens is these patients, when they are given some other antihistaminics or Montelukast or nebulization or some oral steroid, they give an immediate response. But when repeated exposure leads to the late phase establishment, and when there are multiple sensitivities, the mast cells get more hyperactivated, and then the other inflammatory mediators like cytokines or lymphokines, when they are secreted, TSLP, then the patient does not respond that well. So in your practice also, I think most of us have seen that. The last season, the patient, or maybe 2-3 seasons before, the patient was just responding to fexofenadine or cetirizine, levocetirizine. But that patient same complains that now he is not having that much response. So why it depends? Because the patient has gone into the late phase reaction, where then we have to play a multiple, like Montelukast, then we have to go for the biologicals or oral steroids and all, but they have a long-term side effects. And oral and parenteral steroids are overused in India. It is documented because I remember 2020 when I had delivered a lecture on this use, abuse, and overuse of anti-allergics and steroids in India. I found a lot of literature on that, and the steroids are actually used. So how we should have a steroid sparing effect, and besides steroids also not using that, how we can have a very good relief. So I will come to some cases. So this patient was from Kolhapur with severe asthma, blocked nose, much better after the standardized allergy testing precautions, safe medicines. So these hidden dark circles, wrinkles, they were already there. So even adenotomy, tonsillectomy, these are not required. Most of the 60 to 70% of these patients have a dust mites and indoor mold sensitization. You can see like there is a horizontal line at the junction of the soft and hard palate. This horizontal line, then this wrinkling. These are the early signs. And as a practitioners, we can pick up many patients. This young adolescent had asthma, sinusitis, protrusion of the jaw and teeth. You can see the turbinates, they are popping like you can see easily. So these patients, if we manage properly, how in diabetes, we always guide the patient. Any pathology, any pathy doctor, he will always guide the patients that he has to avoid what diet, what type of things has to be done, along with the medication. The same way, these patients, we should guide the patients about what are the environmental factors. They are triggering the allergens. That is very important. And if you see ARI guidelines, even the COPD Gold guidelines, GINA guidelines, everywhere they have mentioned that first allergen avoidance measures have to be taken in these patients. But at present, if you see, most of the patients are being given just symptomatic relief, whatever the medications. Somebody treats with allopathy, somebody treats with homeopathy, somebody treats with Ayurveda, whatever. But the minimal persistent inflammation, which is continued in these patients, the newer sensitivity formation, that is not taken care. And that's why, as I said, once allergy is always allergy till we don't manage it. Only in between, there is a window period, and the patient may not have a significant symptom, but the sensitization and this inflammation continues from the same part of the body or the different parts, and later on he may have a very severe reactions from other part of the body. So the young girl, which has a DNS, headache, bronchitis, last 10 years, all types of treatments were given except the testing and immunotherapy. And the testing showed the dust mites, pigeon, cat dander sensitivity. Desensitization helped her a lot for her progress. You can see the debate and nasal septum. It was a singer. Last 1 year, voice was affected. He had a rhinitis, seasonal. Once we identify the proper standardized testing, we gave a proper desensitization, and his inflammation went down so well. His voice also now has returned. He has started singing. So this has a very good effect. If you manage the allergy, this patient had a repeated throat infection, tonsillitis. Adenoids are a secondary infection. The primary inflammation may be because of the allergy, Th2 inflammation. You can see the posterior pharyngeal hyperplasia. This is a patient blocked nose, sinusitis, sneezing. We did a allergen testing. Then this was a patient from around 65 kilometers, Baramati. And this had a significant bronchitis, always used to block nose, always used to sniff inside. And he had a grass and multiple flower pollen allergies. After the desensitization and safe anti-inflammatory medicines, the patient showed a very good response. This was a 12 years child, had a significant blocked nose, sneezing, eye itching. If you see most of the patients, you must have seen eye itching. So now even American Academy of Ophthalmology has said 100 out of 100 allergic rhinitis patients always have ocular allergy. Hidden signs are always there. And those also should be picked up to improve the quality of life of the patient. 27 years with significant skin allergy, itching, rash, seasonal cold, food-triggered anaphylaxis was also there. And we started on a biologics. The patient was on a steroids. They was very scared. We started on a biologics. The omalizumab was given and the patient showed a very good response. Besides that, the standardized skin test and all, we have to do it. Like a diabetes, we always do the sugar test, C1 peptide level, insulin level, whatever. The same way, a basic is the standardized skin prick allergy test. In some of the patients, immunocap IG or the component resolved diagnosis if there is a significant anaphylaxis or food allergy. The rest of the ELISA methods and RAS tests are outdated, whatever the labs they say. So the specific IG allergen testing is required in these patients. And that has to be done. Only once the patient has to do the test. Afterwards, they can have online consultation also. We can guide the patient properly. It helps a lot. So even the asthma also, seasonal pollen, molds. In Pune, we did a studies in 2014, the pollen sensitization, which pollens are common and all. Then 2008 to 2012, we did a study for 65 severe asthmatics, and we found in their offices, at their schools, children's, in the kitchen, the food particles fall into the deep pockets. Then along with the vegetable fruits also, these molds come, specifically the software engineers and all, the central AC ducts, there is a lot of molds in the lodges, in the common places where the central AC is there. Then dust mites, it's very common. Cockroach droppings, feathers, animal danders and all, they can travel around 15 to 16 kilometers. Pollens can travel around more than 65 to 130 kilometers. During COVID, when the second Delta has been transferred from Britain to USA, it had gone with the pollens. So they travel so many kilometers. And we have to take care of that, and we have to educate to the people so that the adherence of these patients to that doctor, whoever is treating, will be there. Otherwise, these people will just go on changing the doctors. So if you want to have a good adherence of these patients in your practice also, along with the medications, precautions and environmental control education has to be done. Then again, whatever the passive smoking by the parents or grandparents, pollution is a very big problem in the rural areas also, pesticides overuse. Still the burning is going on, added on the effects of that. Strong smells at house, perfumes, cleaners, door cleaners, these are also very big problem. So lifestyle has changed, so they are adding on these effects. Weather changes are so fluctuant. So whenever there is a significant weather changes, like this year, in between there were rains, again it has gone. So the pollens change, and the potency of the pollens and the persistence of these pollens continues for a longer period. Then secondary upper respiratory infection, when there is already TH2 inflammation. Then cold drinks, ice cream, colors, additives, these are just irritants. The patient has to be first sensitized with these allergens, then only they get a trigger by these things. And the misconception amongst the community is that after eating banana, after eating some milk, or after having something, they get a trigger. But these are not a primary allergens. Only 5 to 8% of the children, adults also, previously it was hardly in 0.%. Now it is around 2% food allergy. Because these histamine-rich foods or some of the foods which are a histamine triggering foods, they just trigger the mast cells which have been already hyperactivated into the body. So the primary sensitization most of the time is environmental allergen. Then emotion. In some of the patients, exercise triggered bronchitis, exercise triggered anaphylaxis has increased. Food induced exercise triggered anaphylaxis. I have more than 18 patients. They were previously somewhere rhinitis, somewhere having a conjunctivitis, some had a sinusitis, some had a asthma. Now they had this food-induced exercise-triggered anaphylaxis. So these cases are allergic. Some of the patients get a trigger during the main phase. Some of the patients during the pregnancy. Some of the patients during the menopause. So these are the irritants. So now if you see the asthma, which is a very common chronic disease, and we have to always ask the family history, not only the parents and all grandparents, the first degree relatives, then specific IgE testing with the skin prick test, then any of the viral respiratory illnesses, specifically office going people, school, college going people, exposure to air allergens in that area, passive smoking, obesity as a comorbidity, then depending on the economic status, central AC use, car AC use, when they on the AC, the pollens in a large amount they are get stuck in. And again, if they are using a more AC, the humidity changes into the air, the deep pockets, the dust mites into the cushions, and the pollens they are already into that, and then the secondary funguses happen on these proteins also. If you see, 90% of the children and even 50 to 65% of the adults have a primary allergy. 75 to 85% of the patients with asthma have a positive skin prick test, and 5 to 10% of the people with asthma have occupation or industry-induced airway disease. So now even asthma COPD overlap syndrome is there. So many of the patients are just labeled as asthma, but they may have underlying COPD. So we always should objectively also, we should check for the spirometry, pheno, oscillometry, whichever is required. Now oscillometry is very easy to demonstrate. Even the about 2 years children also can be, this can be done. And there are so many unmet needs into the injury. So high burden of these diseases, non-adherence of the therapy, a lot of patients have again severe asthma or obstructive sleep apnea or COPD, may have a cardiac problems also. And specific traditional same medications may not be applied over there. So we have to always think in a one airway, one disease, one mucosa, one disease. I always say the nasal mucosa, which is the antenna, the inferior terminates. So always check with the inferior terminates hypertrophy, pale, boggy nostrils, deviated nasal septum, posterior pharynx, there is a cobblestone appearance, long eyelashes, denim organ folds. These has to be identified, and then we can guide the patient. If you manage the proper as a one airway, one disease, most of the patients have a very good, and this is a silent killer. Now it is a second death causing disease in India. And the comorbidities also, we always has to find it out in the cardiovascular problems or something. Even these patients which require a repeated nasal steroids and the combined dose of inhaled steroids, nasal steroids, oral steroids may have a glaucoma, early age cataract. Even the localized eye drops are more serious than the nasal steroids or inhaled steroids. So see, these are most safest localized treatments, but overuse will definitely will cause some of the other problems. Even the localized steroids on the skin also getting absorbed. So if we manage these patients with the properly, definitely their inhaled, nasal, ocular, or local skin steroids or oral steroids also go down significantly. And definitely it helps a lot. If you see, the asthma has already increased, COPD is also increasing, and still even many of the patients, the ICS LABA also, they are not showing that much results. That's why if you see now indacaterol, vilantrol, glycopyrronium, so many molecules are pumped in India. So if you see, it has so many comorbidities. Even the GRD, 40% of the patients may have obesity, has to be treated, obstructive sleep apnea. Direct chronic rhinosinusitis will have a secondary infections. Then polyps will cause a problem. Then hyperventilation, glottic dysfunction, psychopathology, smoking, COPD, respiratory infections, atopic dermatitis, aspergillus problems, bronchiectasis. So it's all connected. So we have to always look at the patient as a whole and just not treat the localized organ. Even now it has been found the rhinitis or asthma patient also, their cutaneous sensitivity starts. So like last 4 years, I was working with the World Allergy Organization, severe food allergy or atopic dermatitis prevention programs. And it has found that the barrier of these skins, it may be rhinitis, asthma or sinusitis, their skin barrier is also lost. And you must have heard, जैसे कांग्रेस ग्रास या गाजर गवत बोलते हैं, उसमें से suppose somebody travels, he gets completely severe angioedema, he gets a lot of urticaria. So why it happens? Because these pollens, they penetrate to the skin. And nowadays, even the patients with the allergies, it has been found first cutaneous sensitivity happens to the dendritic cells in the skin by the grains like peanuts, their dust, and later on, once the mast cells into the gut also get hyperactivated, these patients may get a trigger by the oral ingestion, sorry. So these things are happen. So cutaneous sensitivity is also important. Even the rhinoconjunctivitis or asthma patient also, we should always give them a good care of the skin. So use a good moisturizers, use a normal pH soaps also. Now, rather than allergy, I will say that this type 2 inflammation, Th2 inflammation is talk of the town. And these are characterized by the interleukins, which are often produced by the adaptive immune system on recognition of the allergens. In Pune, with the Pune University National Cell Science Laboratory, we did a study for the asthmatics, and we found significantly increase in the IL-3, IL-4, IL-5, IL-13, even Th2 also. The cost of these tests are high, but during the COVID, IL-6 levels were analyzed. Why? Because multiple times, many of the people were doing, so the cost came down. The same way, if we start acting on this, we can definitely help these patients because targeted therapies will be there against these interleukins. It also may be activated by viruses, bacteria, irritants that stimulate the innate immune system via production of IL-33, IL-25, and thymic stromal lipoprotein, TSLP epithelial cells. Now in Pune also, in Sahyadri, we are doing a trial for severe asthma and COPD, itiquimab, which is against the IL-33. So these will be the target therapies. I am doing a trial on omalizumab also. We are already using bendamustine, dupilumab, as well as the mepolizumab in Pune. So now this will definitely help to reduce the type 2 inflammation and to improve the quality of life of the patients. So if we manage the patients, if you see 66% of the asthma patients in India report exacerbations in the previous year, 83% of the Indian asthma patients using rescue medication. Even 2014, Doctors Republic site in India has established that 92% of the people who claim that their asthma is controlled, none was properly controlled when the spirometry was done. So if you see the severe asthma also, still whenever we label these patients, always look for the proper techniques, any medication adherence, because once the patient is better, they leave the treatments. So it should not also happen. We should always see for any of the other comorbidities, and we have to treat that also. And these methods, like as I said, oscillometries and all, these should also be practiced in India now, which can really pick up the inflammation, and even the pheno-XL nitric oxide. So some of the patients, they feel they are controlled. So they will always ask me when I can stop the inhaler. But if the pheno level is high, or you would say eosinophilic type of inflammation, then maybe we have to increase the dose of the inhaled corticosteroid. Because long-term wise, the patient should not have a severe relapse afterwards, or the repeated relapses should not be there. So these objectively also, it helps a lot. So basically XL nitric oxide, and there are different type of these uses, and it should also be. Now even the nasal oscillometries and all these will be there. So how we can achieve a complete and proper treatment, because disease modifying therapy is always the allergen immunotherapy, because that is the only one. After withdrawal of the medications also, the control of the disease can be for a longer period. And as I mentioned, the genetics and the environmental changes are already happened, and it is a hypersensitive response. Even many of the people, they feel like it is a lower immunity. It is not that way. It is a hypersensitivity. Even to be having allergy, there has to be a good immune. So it's a hyperimmune response. So this has to be educated for doctors also. I have seen many of the Ayurveda or homeopathic doctors, they have a misbelief that it is a lower immunity, and they say to the people that they take a people's ignorance about this disease. And what they say is that we can increase our immunity and we will cure the disease. So it's a false security to the people. And then they land up into all these chronic respiratory diseases. So coming together, we should always educate the people that symptomatic management is different and the disease progression management is different. Even a lot of people, they feel food allergy, but it is an intolerance. And that's why intolerance may have a GI symptoms and other like problems of skin problems and all. And there is a connection of all these allergy, asthma, COPD, autoimmune disorders, immunological problems. And if you see the why it has increased, as I said, the sensitivity from the skin, then depending on the lifestyle, exposure to the farm animals, it is less now. Natural, previously used to have a big families, now nuclear families. So the natural infection, the hygiene therapy we call. That's why Th2 intolerance, and then it leads to the, and this is such a burden into the people. And as a practitioners, always in maybe children, adults, always look for the bluish black discoloration, which is because of the venous stasis, long eyelashes, then this Muller's muscle spasm. Many of the people will say, okay, because of lack of sleep or not eating calcium and all, it's not that way. Now the things have changed. And many of the people have watering of the eyes, frequent blinking, discharge, dryness, heaviness of the eyes, irritability. These also signs can be picked up. Mouth bleeding, this allergic salute like rubbing the eyes or ears. These also should be picked up by us. Looking at the inferior terminus, there is a horizontal line on the nose, hard and a. By doing this, there is a fold over there, facial grimaces like this. Then just simple temperate hypertrophy, posterior pharyngeal hyperplasia. So these hidden signs we have to, and always remember this classification, because see, type 1 allergies we are managing, but if you see the eczemas, which have been increased now in adolescent adults, it is increased a lot. Periocular eczemas, VKCs, there is a type 1 and type 4 both combinations. Then depending on the type 2 and type 3 reactions also, the blood transfusion reaction, so many things are there. Allergy covers all of these. So if you see the patient when he becomes older, he will develop a more and more other respiratory complications. Even the adult food allergies are also increase. Anaphylaxis is increasing because of the changing pattern. As the child increases, as the child grows, he will lead to asthma, rhinitis, rhinosinusitis, VKCs and all. So this minimal persistent inflammation and threshold level for the symptoms may be achieved later, but the inflammation will be controlling. And that's leading to the drug-induced anaphylaxis, food-induced anaphylaxis also. And the comorbidity also among the rhinitis, 40 to 50% will have asthma. Amongst the asthmatics, 70 to 90% in children, adults 50 to 65%. Dust mites, 80%, pollens, 20 to 23%, cockroaches, animal dander, 5 to 7%, molds, 13%. If you see this, it's very high. And how to diagnose these patients? Early detection is very important by all the guidelines. Even European Academy 2017, being a part of the rhinoconjunctivitis allergy immunotherapy. I was as a faculty review author. Again, last 4 years working with WHO, 6 years working with the ASCCI on the environmental committee. I have found that they regularly guide the patients about the avoidance, decide the symptomatic management, and those selected patients, the immunotherapy also. And if there is a GRD, then we have to give a long-term PPI inhibitors also for the 3 months or 6 months, depending on that, and changing the diet. So which patients we can do the allergy testing from top to bottom, like even rhinoconjunctivitis, the skin eczemas, specific urticarias, food-induced allergic asthma, rhinitis, rhinosinusitis, even 30% have otitis also. So those patients also it helps. And if you see even mild to moderate patients, it is more significant, and we should demonstrate that. So once the patient goes into uncontrolled asthma, then they may not respond that well, because then multiple players play part, and then it becomes difficult. So then we have to use a biologics also along with that. But if the patient, when is a mild persistent, mild to moderate or severe persistent, there if you can help, the patient show a very good response. You can see standardized skin allergy testing, 85 to 90% of the patients show the response. And clinical symptoms, medical history, it takes around half an hour to 1 hour to demonstrate all the factors, the environmental, and then we should always go for the only challenge test for the food allergy or drug-induced allergies, but it is very risky also. Very few patients, they really require a challenge test. Most of the time, skin test is a gold standard. Very few people may require an intradermal testing in contact allergy, patch testing. Then blood test, if you want to do in a specific patients, where all the skin is involved because of some or the other reason, and we can't demonstrate the skin prick, then the specific IgE immunocap or component resolved diagnosis is the very helpful now. And you can see like how all the organization has mentioned about the standardized skin prick test. It is painless, bloodless as compared to the blood IgE testing. It is cheaper also, hardly 100 rupees per allergen, while immunocap they charge around 700 to 900 rupees per allergen. So there are no side effects of the skin prick test, and most scientific and research and practical benefit is that the skin prick test will determine the mast cell bound IgE rather than the blood circulating IgE. Blood circulating IgE may be picked up in a false positive way in the blood test, where the sensitivity may show high, but the patient may not have that much symptoms. So always after the blood allergy test also, whatever the positive things, we always go for the skin prick test. Immediate results are there, cost effective also, and very easy. Even it is more safer than the venous puncture. There are studies done, and you can see the percentage wise how the benefits of the skin prick. The standardized allergens, 3 millimeter with the histamine positive control, whichever positive indurations are there, like a mosquito bite, and within 40 minutes, the patient's reports are in our hand. There are specific 1 millimeter tips available. You can see it's painless, bloodless. Okay, and there are no reactions also. Standardized allergens, the batch to batch variability has to be checked. That's very important for that. And now the latest one, last 1 year, I am using the component resolved diagnosis in those patients where they suspect like it is a food allergy. But clinically, I found it doesn't have. But to confirm them, we do this artificial intelligence uses multiple microarray assay method where we can differentiate these RAH123 and all. What is the peanut anaphylaxis? Suppose patient has RAH123, there are chances of significant anaphylaxis. And suppose the patient has a milk allergy, and if you find out the casein, the patient can use the milk by boiling or baked product. Latex sensitivity is there is a cross reactivity with the citrus fruits or other fruits. So sensitivity can be also analyzed. Cockroaches and all. The airborne or environmental allergens, there is no need of going. Insects also, very few patients, if we want to give for a significant immunotherapy and anaphylaxis is there. And if we can't demonstrate the skin prick test, then we can do for that. So these eggs also, GALD 1, 2, 3 and all, we can analyze. So some of the patient, the component resolved diagnosis also can be done. So we have to utilize the allergy diagnosis in our clinical practice. Once we identify that, we can definitely stop the allergic march or progress of the disease, which is called a desensitization. So consider that it is a systemic disease like a diabetes. And as a practitioner, our role is that to manage with the awareness measures, like suppose dust mites in there. There are standard guidelines for the environmental control of that patient. What type of fabric can be used, as a dust mite proof covers can be used. Pollen avoidance, depending on that winter season, if there is a smog, these are trapped down, the pollutants and all. The people should use a pollen filtered mask or dust filtered pets. It should not be kept on the sofas and in the bedroom. They should be kept outside. Cockroaches, then control of that. Molds, then liquid ammonia 20% can be used, and which can be used. Now the pharmacotherapy, if you see, still in India, last 34 years I am seeing people have a misconception about inhaled corticosteroids. They feel that it is addictive, it has a side effects, and uski aadat lag jati hai. So what has happened then? Since so many years, still we could not convince our patients that these are the most safest treatments. It directly acts over there, and whatever the exhaled product goes out, it does not have a systemic absorption. Rather than that, 2003, if you see the Times of India article, there was said in a lot of people, they are mixing the steroids and they are using. So here the oral steroids are used, and inhale and nasal steroids are so safe. They don't have much side effects, only the proper direction and the proper technique. And if the patient is using that, after that gargling and all, that also should be guided. And specific allergen immunotherapy can be used for the dust mites, pollens, some of the animal dander, insects. That will be really a game changer, because these specific IgE which are formed, these form the IgG1, IgG4 antibodies into the body, so that the further sensitivity, newer sensitivity is also stopped. So allergen immunotherapy, basically it's a administering of the gradually increasing quantity of that purified allergen extract in a sublingual, oral or subcutaneous shots. Sublingual immunotherapy is very well now practiced in India because It can be taken at home, even above 2 years children also. Subcutaneous above 8 years. Oral immunotherapy tablets are not so routinely because the cost is very high. In subcutaneous immunotherapy, the patient has to be in the hospital. Sublingual immunotherapy is very well. Immunotherapy, the IgE-mediated diseases like rhinitis, conjunctivitis, asthma, large local reactions to the insects or anaphylaxis, sensitization to the relevance of the symptoms after the allergy test. Always try to clinically correlate the symptoms of the sufficient severity and duration and availability of the standardized stats also. This is the only therapy which will reverse this Th2 to Th1. Because these allergy patients, the Th2 inflammation rate increases, the Th1 suppression happens, and then they get a secondary infections leading to sinusitis or severe pneumonias or other systemic gastrointestinal or any other otitis and all. This Th2 Th1 balance, if we can make it, the patient's secondary infection also can go down. And as in the early childhood, if we manage these patients, they have a very good results. Even now, the future is on biologics and probiotics also. There are very good anti-allergic probiotics. Specifically, the research has shown very good benefits for the pregnancy. During pregnancy, if the mother's also supplemented, the severe eczema, atopic dermatitis can be prevented. And there are specifically, the future is also on, and these also can be practiced in our practices. So if you see 1998, the World Health Organization, there is a position paper which says that symptomatically, if you see all of us are managing antihistamines, then Montelukast, then nasal sprays, inhaled corticosteroids and all. Even Montelukast is very safe. See, consider the effects and side effects. Considering the oxidative inflammation leading to the carbon dioxide respiratory acidosis, cognitive behavioral disturbances, overuse first generation antihistamines leading to the accidents. 78% of the accidents into the driver happen because of the first generation antihistamine. So whenever we want to use antihistamines, use the safer second or third generation. It's very safe. Even in a severe urticaria or rhinosinusitis, we can use the fexofenadine, bilastine in 4 times dose also. Even I have given 80 milligram bilastine in a pilot also. Fexofenadine up to 720 milligram. It's very safe. So even the mast cell or biologics like omalizumab, mepolizumab and all. But besides that, always guide the patient about the allergen environmental control. And those selective patients, immunotherapy can have a very good, like omalizumab. It has a multiple actions. Binds to free IgE, decreasing the cell-bound IgE, the FCR receptor at the mast cell, decreases the expression of high affinity receptors, decreases the mediator release like lymphokines, cytokines, or histamine, decreases the allergic inflammation, prevents the exacerbation of asthma or rhinitis, rhinosinusitis, leaves inflammation also, release of the mediators, mast cell basophil or eosinophil also reduce, IgE antibodies are also reduced. So it has a multiple actions. It is one of the timely tested add-on therapy for severe persistent allergic asthma, polyps, severe urticaria, some of the eczema patients also. Eczema severe, dupilumab is much better. Even now, dupilumab is used above 6 years. Mepolizumab also is used above 6 months. There are very good guidelines. When benralizumab about 12 years is available now. So you can see that, and we have to assess the, if everyone is less than 70%, have to wait, let the asthma control, and then only these biologics can be given. If you see the 2017 allergy immunotherapy guidelines, I was also one of the part of this discussion at Bangalore. The allergen focused medical history, once we suspect an allergy diagnosis by the skin prick test. These 2 things has to be done besides the nasal steroids or inhaled steroids or Montelukast or any of the antihistaminics. Then if the patient allergen avoidance and simple precautions and all cannot be managed, and there is a definite dust mites, pollens, animals or insects, then the desensitization, even the children's, the indoor environmental control has shown a very good results. And it is really useful. And many of our own colleagues have a block. Like these managements, are they really costly? Considering the repeated medications, considering the minimal persistent inflammation, newer sensitivity formation, leading to the adult severe allergies, asthma, chronic respiratory diseases, requiring so many hospitalizations, repeated medications, side effects on the oral steroids, side effects of the first generation antihistaminics like indirect accidents, cognitive behavioral disturbances, poor quality of life. The allergy testing and the immunotherapy is very cost effective because as a practitioner, I had a hospital also, I had a 100 to 200 OPD. I have seen that difference also. And since when the standardization into the allergy testing immunotherapy has come and we are using, we have seen the difference of management and improvement into the quality of life and overall reduction into the cost also. Long-term wise, the complications are also avoided and long-term cost is also reduced. And the patient's medication also come down. This was one of the whole family had the problem. Like this girl had a process, this younger sibling had a eczema, the father had a severe asthma. And so if we can, as I said, last 4 years, I'm working with WHO for these prevention programs and all. If the parents, you can analyze and you can manage it properly, the severity into the next generation also can be reduced. So this was a patient with a significant urticaria last 3 years. We did a testing. This was a patient with a corn anaphylaxis. And he was rushed to the hospital. These type of so many complications we can. This was a young girl. We had a paracetamol triggered anaphylaxis. You can see the protrusion of the you can see here notch and this dark circle also. You can see the turbinates in the same girl. Significant posterior pharyngeal hyperplasia. It changes if we can pick it early and if we can manage properly, we can definitely prevent so many of these complications. Like yesterday only, I had a call from one of the ophthalmologists. The patient was operated for the cataract. The surgery went very well. And post-surgery, the eye drops, it caused a significant angioedema of both the eyes. They were so scared, relatives, and they started blaming the doctor. So she called me, what to do now? So I got the patient, I saw him, I explained to the family, like nobody can be a predictor. So there were hidden signs of allergies and all. If we would have treated that, maybe she did not have that such a severe reaction. I remember 5 to 6 years back, one of the doctor during a small abscess operation, he died with a cardiac arrest something on the table. So many surgeries we do, and such a small abscess, why cardiac arrest will happen? So it can be anaphylaxis. So many, one of the very well-known MLA from Pune, during the MRI, he had a just iodized salt and he died on the table. So we can prevent such type of severe anaphylaxis also. And even in Delhi, 16 years old girl, few years back, some Sakshi or something, she could not be rushed to the hospital. She was a known case of asthma, but that time she made an anaphylaxis because there are few cases, maybe 2 to 5% can have a significant anaphylaxis when they had asthma. So these are all overlapping things. And if we can manage the allergies better way with a proper approach, specific skin prick or specific IG allergy testing, once we identify a simple precautions, a simple non-side effect anti-inflammatory medications, and wherever they're required, suppose steroid sparing treatments, the biologics and all, it can help a lot. And allergen immunotherapy is one of the very good disease modifying therapy. Last 130 years it is practicing worldwide. And that awareness, and along with that, the objective markers, spirometry, though awareness has to be improved, but even along with that, pheno oscillometry awareness also should be brought in India, the rhinomanometries and all. And if we start practicing these things, definitely we can change a lot. I remember 2019 when I had been to the Professor Baylor, like this is a skin department, but they had 3 oscillometries, 6 spirometer and 4 pheno machines in a dermatology department. And so many patients were waiting for all these legalizumab. In a day, I have seen 20 to 25 patients taking legalizumab. So these are steroid sparing treatment, and these all biologics and all nowadays are covered in insurance also. Even allergy testing immunotherapy is also covered in insurance, and it can be utilized very well. Thank you. Thanks a lot.
Thank you so much, sir, for such a insightful presentation from your side. So there are some of the questions from the audience side. So one is the basic question. So basically, whether there are more chances of the development of the allergic rhinitis. Is there any specific weather?
Weather.
Weather.
See, practically, the winter, the dust mites and pollens, they increase a lot. So there are always chances of more anaphylaxis.
Okay.
Yes.
Yeah. Second question is, you mentioned about the food and the relation of the food and allergic rhinitis. So is there any specific food that lead to the development of the allergic rhinitis or the anaphylaxis?
No, basically, allergic rhinitis is not developed by the food. It is triggered by some of the foods. Allergic rhinitis, asthma, most of the time, it is all environmental or airborne allergens. Once the patient is already, the mast cells are hyperactivated, then some of the histamine-rich foods, or there is a oral food allergy syndrome, pollen food allergy syndrome. So there is a cross-reactivity. Like suppose somebody is dust mite sensitive, and if he has a prawns, the prawns have a tropomyosin in. There is a cross-reactivity between these proteins. So that's why these people get a anaphylaxis also. Then again, as I said, suppose somebody is a latex sensitivity, and if he has a fruits, there's a cross-reactivity of latex protein, epitopes we call it, with these citrus fruits or some of the fruits. So that's why these people, after having that fruits or food, get a trigger. So it is because of that. So it is not a primary food allergy, it is a secondary. Primary food allergy means suppose somebody has a food, within 2 to 3 hours, he has to show a reaction. It is not respiratory. Most of the patients, they have a severe stomach problems, puking, or they get a collapse, hypotension, like a shock like anaphylaxis. Then angioedema, urticaria. These are the common symptoms, skin manifestations and GI symptoms, and the systemic like a shock like syndrome. Very few patients have a asthma trigger or rhinitis. Very few patients.
Okay. Thank you so much, sir. Another question is, you mentioned in your talk about the inhaled corticosteroid. So there's a misconception of the inhaled corticosteroid in the patient with the allergic rhinitis. So how long do you prescribe the inhaled corticosteroid in patient with the allergic rhinitis?
Inhaled corticosteroids can be given a longer period also. 2013, John Price had been in Hyderabad for a consensus on asthma, rhinitis and all. So even the Montelukast also they are using for many years. So depending on the seasonal exacerbation, if the patient has a perennial allergy and his exacerbation is more in the winter or rainy season, depending on that, we have to adjust the dose. Some people have very severe rhinitis. So that time we have to increase the 2 sprays also for 2 to 3 months. Then we have to come to 1 spray, then alternate day. So each and every patient is different, and his trigger in what type of season. Most of the patients have a trigger in the rainy or winter season. So that time for 2 to 3 months also we can give it very safely. Only the direction has to be on the turbinates, not to the septum. Otherwise, then it causes epistaxis or crusting and all. So, or some of the patient, even the azelastine also can be combined for a significant rhinorrhea or itching is there for 8 to 10 days. And then again, you can shift to the plain inhaled nasal steroids.
Right. Thank you so much. So related to the on the same part, that is with the inhaled corticosteroid. So is there any specific precaution do you want to say on to the audience?
Yes, always see whenever inhaled nasal steroids are used, it should reach to the proper inferior turbinates, because these patients, the inferior turbinates are the antennas. The allergens, pollutants, they come here and then they sensitize here. They may not penetrate completely into the sinuses or the airways. So sensitization is from the inferior turbinates. So the action mostly has to be on the turbinates only. And before having that, we have to always have a proper nasal wash. Otherwise, if there is a mucus or serous secretions and all, then that spray may not act over there. So if you wash the nose properly with the nasal mist solutions nowadays, or there are nasal wash bottles available, and then you use it, it helps a lot. Then after using that obliquely and proper pressure, just tap it properly. Whatever outside comes, they can clean it. There is no need to sniff inside. If they sniff inside, it will have a postnasal and more bitterness and nausea and all. So the tolerance the compliance of the patient is not good. So that's why that also should be properly practiced.
Okay. Thank
And
you
before
so much,
that,
sir.
always shake it properly. Shaking is very important.
Yes, sir. Thank you so much, sir. Sir, right now there are no more questions from the audience side. So do you have any closing remarks from your side?
As I mentioned, how we manage the diabetes or blood pressure. The same way, the allergy management concept should be brought into the community, and coming all of us together only can make a difference. Otherwise, these patients are just running from one doctor to another doctor, but their progression of the disease inside the body is not prevented. That's why so many people are practicing in allergies. So many doctors are practicing in allergy. But why we could not stop the chronic respiratory diseases? So many people have getting operated for the DNAs, polyps, sinuses. Still, their quality of life is so poor, because how in diabetes we always guide the patient about precautions. In allergic diseases also, we should look the patient as a completely, as I mentioned, the cutaneous sensitivity also starts. So the skin care is also important. The nose, proper hygiene also should be mentioned. And the safest medication should be practiced, because it is a long-term disease. It has a multiple implications: the lifestyle, stress, food habits, adulterations, environment. So many factors are playing into that. And genetics is also very, very important. So somebody suppose is going to have a severe genetic allergic tendency, he's going to have it, but we can improve the quality of life with the proper environmental control as well as the proper diet and stress release. So it is an integrated approach or holistic approach, we can say. And we have to give a lot of time to these patients, educating about these things also. Otherwise, the people will feel that another doctor giving one injection and one small tablet, I'm having a relief, and this doctor after giving 10 days also I'm not having relief. So we have to always educate that will have a long-term side effects. So you have a good, safe medications also. And then some of the patients which require allergen immunotherapy, that is a disease-modifying therapy, no side effects, absolutely, it is the most safest. How we give a polio and all. So that awareness also should be there, so that we can really help the patients to stop these long-term chronic respiratory diseases, side effects of the medications also, and adherence of the therapies also. Thank you.
Thank you so much, sir. Sir, can we close the session?
Yes, please. Thank you.
Okay. Thank you so much, sir, for such an insightful and insightful presentation from your side. Also, the awareness talk on the allergic rhinitis in this month. Also, I would also like to thank the audience for their presence for the today's meeting. Thank you so much.
So now, ma'am, with your permission, can I end this meeting?
Sure, sure.
Yeah. Once again, thank you everyone for joining today's session. So now from here,